So we'll have a change of pace. It's very serious, so I'm going to make it a bit more lighthearted. And when I try to remember the first time I met Pete, it just dawned on me that my mentoring style now was largely influenced by Pete as well as Roger. So I came back here in Boston in 2007. I was actually here in the 1990s to do my infectious disease fellowship. And yes, I'm in my 50s, that's how old I am. And then I had trepidations about coming back to Boston, to Harvard and MIT, because I remember Harvard as being a very toxic world. It's a dog-eat-dog world, and I wasn't sure I want to go back to this sort of environment. But I didn't get into Stanford, but I got into Harvard and MIT, so I found myself coming here. And it was actually Renilda, who I thought was going to be here, who introduced me to Pete. And Pete said, "Oh, you're an intensivist. You should come to our next meeting about Mimic." And that really had an imprint on me. That so the way we choose people in our lab is we don't fully vet them. Like, I think the idea there is if you create a good enough environment, people will shine. And it doesn't matter how. So I don't take my time really looking at the CV. Is this person going to be a good fit? But if I think I could provide a good environment for them and provide them with a good network, that everyone will step up to the plate and everyone will be able to really realize their full potential. So with that in mind, I thought I was going to be a little bit tongue-in-cheek and talk about some of the questions that get asked of me when we speak about data science as applied to healthcare, AI as applied to healthcare. And some of the answers I actually give to the audience, but some of them are going through my mind. I wish I could give this in public, but I probably shouldn't. So the first one is, data science does not establish causality. It gets asked every single time. So I have a prepared canned answer to this one. And my answer usually is, do you know what fraction of what we do in medicine is based on clinical trials? And the studies have been done. So I work in an intensive care unit. And in intensive care unit, it's about 9%. 9% of what we do is based on prospective randomized controlled trials. And we're just 1% behind the highest specialty, which is cardiology, which is at 10%. Oncology is around 6%. OBGYN, pediatrics, surgery is about 1 to 3%. So if you're going to say to me that we cannot trust anything outside of a clinical trial, then we're in serious trouble because we don't have enough trials to support what we do in healthcare. And this is just looking at prospective randomized control trial. We're not even talking about the quality of the randomized control trial. And one thing that I've been teaching the residents, the fellows, and the people I work with, when they read a prospective randomized control trial, is to quickly calculate the fragility index. So fragility index refers to the number of patients, if they had a different outcome, would completely change the conclusion of the study. And what you'd like is a fragility index really that's very high, so that the findings are kind of robust. And again, going back to the ICU, we find that in 1/8 of clinical trials that have been performed in the ICU domain, the number of patients who were lost to follow-up was greater than the fragility index. So it means that we cannot really fully be confident about the conclusion of those studies. The median fragility index of a clinical trial in the ICU is about 2 patients. So it would take 2 patients. If they had a different outcome, the conclusion would be the opposite. And that 40% of trials performed in the ICU had a fragility index of 1 patient. The other way to address that question, that data science cannot establish causality, is you believe in these 2 statements. Vaccines do not cause autism, and smoking causes lung cancer. And I could tell you that there was no trial that randomized kids to vaccines. There was no trial that randomized people to smoking, right? These are based on observational studies. And I guess there's a difference there because the effect size is a little bit bigger for this particular use cases. Second question, which always gets asked, is what about patient privacy? And this is the answer I wanted to give, but I couldn't give. And it's a joke that I actually heard. It's not my joke, but for today, I'm going to say it's my joke. And it's about two friends who are talking. And the friend was whispering to the other friend. And the friend said, "Why do you keep whispering?" And the friend said, "I'm afraid that Mark Zuckerberg and Jeff Bezos are listening to us." And the friend started laughing. And the other friend started laughing. And Alexa started laughing. And Siri started laughing. So people don't have a clue of how much of our data is out there already. And they're worried that they might figure out that my blood pressure on this certain day in the ICU is 100/60. But in fact, all the companies are probably already have all that data about us. They know who we're sleeping with. They know our next appointment for the dentist. So again, I'm not trying to trivialize patient privacy. I think we're all for transparency here. And that to me, the patients always have to be involved in the way we use data, and we need to establish trust. But again, I think the concept of privacy is changing with every generation too. I think that the millennials now have a different concept of privacy as compared to us old people. What about data quality? What about the concept of garbage in, garbage out? I just wanted to remind people that we've come a long way with data quality. So the left side is the font being used by doctors when they used to write in their medical records. And the other one is just a joke about this font that has been, for some reason, preserved over time. But I could tell you that even within the last 10 years, that the data quality has improved markedly as people realize that there's so much value to the data that is being captured in the way we take care of patients. I think people are going to put more effort in making sure that we're capturing the right data. And also, I think one of the most exciting AI domain for clinicians is the area of digital scribe. As you know, more and more companies are looking into the possibility that you will have machines listening into rounds, machines that will be recording encounters, and that the machines will be able to come up with the documentation of what happened during rounds, the discussions that happened, as well as the encounter, so that we spend less time putting in the data in front of the computer. Another comment that we always get, it takes 17 years for research evidence to reach clinical practice. By the time AI is incorporated, we'll all be dead. But I could tell you that there is some paradox here. And this is the NICE, the National Institute for Health and Care Excellence, which some of you are familiar with. They have partnered with the British Medical Journal, and what they do is they go through treatments that are tests that are being offered in the UK, and they look at the evidence behind these treatments and tests. And what they find is that 40% of tests and treatments that are being implemented in the UK have some level of evidence, not necessarily good, but at least there's some evidence. About 50%, there's really no good rigorous evaluation of those tests and treatments, but somehow they found their way in clinical practice, and 10% were actually found to be ineffective or harmful. This is another study from Vinay Prasad. So, yes, okay. So they looked at evaluation of current standard as published in the New England Journal of Medicine from 2000 to 2010, and they were able to find 363 papers. And what they found is when they started studying standard of care practice, in 40% of the time they found the opposite, that test or treatment actually was ineffective or harmful, and it led to the reversal. And the conclusion of the author is that we did not perform enough evaluation before the practice got adopted. And it's sort of, on one hand, they're saying that it takes 17 years for research evidence to make its way into practice. On the other hand, we're adopting practices tests and treatments that have not been rigorously evaluated, and somehow they get adopted very quickly. So as you can see, there's some paradox here. And this is from the Institute of Medicine. They looked at clinical practice guidelines that are being used by clinicians in the United States. And their conclusion is that for many clinical domains, high quality evidence is lacking or even non-existent. And most of the things we do is based on expert opinion, which reminded me of George Washington. At age 67, about 3 years, close to 3 years shy of being president of the United States, he woke up one morning, short of breath, with a sore throat. A few hours later, he developed a fever. And in the next 12 hours, the doctors drained 40% of his blood volume. And of course, this is a practice that was widely used for all sorts of conditions back then. And as expected, he died after they removed 40% of his blood. And for us right now, that practice, which is not based on evidence, but is based on expert opinion, seems primitive and ignorant. But I could tell you that it's still happening in medicine. What about algorithmic bias? Well, the quick answer there is, what about doctor bias? So at least algorithmic bias we could test for, and we could try to mitigate. Doctor bias, we never get evaluated whether we have racial or gender bias, and nobody really corrects us in the way we treat patients. So what about doctor and other clinician bias? So a study in BMJ said that if you present with a stroke to the emergency department, there's a 9% chance that you will be misdiagnosed. If you're a woman, that risk is higher by 30%. And there's also the race bias. So when they compared people with severe depression, they found that African Americans are 4 to 9 times more likely to be misdiagnosed with schizophrenia when they present with a constellation of symptoms that are indicative of severe depression as compared to white patients. So that's my typical answer to algorithmic bias. It's almost very analogous to self-driving cars. And yes, self-driving cars will probably not be as good as humans, but at least self-driving cars will not be drinking and driving, texting and driving, or driving while after having worked 24 hours previously. I'm almost done. Doctors will never trust black box algorithms, and that's why it will never make its way to clinical practice. This is just some of the drugs that we use in day-to-day practice where we have no clue what their mechanisms of action. And an interview with a chemist in the UK, he said that if we threw out all the drugs for which we do not know the mechanisms, we wouldn't be left with a lot. So again, I think we're having some double standards that we cannot use black box algorithms, but we could use medications that we have no clue how they work, but we know that they're working. So why the double standard? Will I be replaced by AI? And just a quick historical review. In 1900, 40% of US workers were farmers, but by 1999, farmers make up 2% of the US workforce. And this is just a graph of showing women who used to work by washing clothes. So as you can see, it peaked in around 1910. In 1910, they introduced washing machine, and you could see they got wiped out. Now we hardly see men or women who would work to wash clothes. But I could assure the clinicians in the audience every time that I don't think that there will never be a role for doctors. I just think that the role of doctors will change over time, and that the value of doctors will lie in the grayscale space where they will support patients in navigating through uncertainty. So I think the patients will be presented with more probabilities and trade-offs, and as clinicians, our role is to help them understand what these numbers mean. And that this comes from Harvard Business Review. The new smart will be determined not by what or how we know, but by the quality of our thinking, listening, relating, collaborating, and learning. And finally, the public will never trust AI. And it reminds me of the story of Oscar the cat. Oscar the cat was born in 2005, and he was one of 6 cats that got adopted by the Steer House Nursing and Rehabilitation Center in Providence, Rhode Island. And the staff observed that he's adopted this behavior of rounding. So he would look and sniff at the different residents of the nursing home, and he would be indifferent to most of them, except that once in a while he would enter a room and curl up at the foot of the bed, and not invariably that patient would die within a few hours. And he became so accurate that it became protocol for the nursing home to call the family as soon as they find Oscar the cat lying at the bed of the resident. And then they interviewed the families of these patients. A lot of them ended up dying. And how do you feel about a cat making these predictions and them calling you because based on the behavior of the cat? And this is what one of them said. It's not that we trusted the cat more than the nurse, not exactly. It was, well, there was just something about Oscar. He seemed so convinced of what he was doing. He was so clear in his intention and his medication. So if we could convince the public that you could trust a cat's mortality prediction, then maybe we could convince them about AI as well. Thank you.